Just trying to change my view so I can see what's going on. Great. So welcome everybody to this workshop. My name is Mark New, and I'm the director of the ARUA Centre of Excellence on Climate and Development, and we are jointly putting on this workshop with our colleagues from the African Centre of Excellence in Inequality Research, which is headed by Professor Murray Lebrant, who's also in the audience. So I want to quickly just share my screen and give you a quick introduction to what we're going to be doing today. So if you just bear with me, I will try and do that. So we're going to start off with these introductions that we're having now, and a little bit of an icebreaker to get a sense of everybody's sort of opinions on the issues around climate change, inequality, and health. And then the program is going to kick off with two plenary talks, which help us set the scene and get us thinking about the links between poverty, inequality, climate change, and health. And I'll introduce those in a bit more detail in a little while. The first of those will be on multidimensional poverty and health inequalities in Ghana, to give us a sense of what it looks like in a particular country. And then we're going to have a talk on the introduction to the linkages between climate change and health impacts in Africa, but with a bit of a focus on some work that's been done in South Africa. So that should take us through the first hour of the workshop, and then we're going to go into breakout group discussion, because we really want this to be an interactive session where we draw on the interests and expertise and experiences of everybody in the group. And we're going to be really discussing three key questions within this breakout group discussion. So one, trying to dig down more deeply into the interactions of dependencies between these three sort of SDG domains: health, inequality, and climate. And we really want to be drawing on people's own experiences and examples there. So, you know, the participants have got experience on the ground, but we're looking for concrete examples that can illustrate some of those issues. We also want to try and understand where the knowledge gaps are. So where, given all these interactions and dependencies we've identified, where do we have strong evidence already, and where do we need to do more work to generate evidence so that that can inform health policy and practice? And then the final thing we'd like to talk about is where the issues are in policy and practice that could be improved given our existing knowledge of what's going on. So do we think there are gaps in knowledge uptake, given what you already know, that we could people could work to provide inputs to, given the existing evidence that we have? We'll finish off with a very short period of plenary feedback, and where we'll just get each breakout group to present a few highlights. So it's not going to be a long discursive effort, because we will have notes taken that we'll compile, but just to sort of just give us pointers as to what the most important issues were that came out in the discussion. Okay, so we've got quite a large audience and quite a packed agenda. So what we thought we'd do is, rather than getting everybody to introduce themselves at this stage, we'd leave that for the breakout sessions, where people will introduce themselves to their colleagues in the breakout groups. But we wanted to just do a little bit of a survey amongst all of you to get a sense of where people think the big issues are. So to do that, we're going to use Mentimeter, which I'm sure many of you are already familiar with. So there are two ways to go about filling this in, either on your mobile phone or on your computer. You can go to www.menti.com and you can enter the code 1420095, or if you have a mobile phone, you can just scan the QR code that we have that I've displayed on the screen. So I'm going to leave that there for a few minutes and then take you through what we're going to be. So just 30 seconds to enter the code 1420095. Perhaps Hajir, if you can also put that in the chat. I can't do that at the same time as sharing my screen, or even simpler, just scan the QR code. So I'm going to give you now. I've got sort of 15 seconds left for that. So most of you should have managed to get your way there. So if you'll just excuse me a moment while I just to Menti. I'm sharing my screen now, so you should all be able to enter your result into the Mentimeter. I'm hoping. Tells me voting is closed. Shit. Open the voting. Sorry, I'm kind of struggling a bit here.
There's another slide underneath, slide 2. I think you should be able to get the results.
Actually, no, the whole thing's closed. So this is a bit of a cock up on my side. Pretty sure I had this sorted.
Okay, there we go. No, just underneath.
Oh, that's the next next thing in the thing. So
okay. Okay.
You got so have you people actually answered this? Sorry, I can't see what's going on the main screen now, but yeah, okay. Sorry about that. So are you busy filling in the second one now? Mr. Darlington, is that right?
Yeah.
Okay. Please go ahead and fill that in. I don't know why the first one didn't work, but so here we're asking what are the most significant dimensions of poverty and inequality in your country or the country where you work. So it's interesting to see that we've got 31% of people have income. We've got education, health, wealth as being sort of accumulated assets and income as opposed to day-to-day income coming through. Health, education being important. Interesting that food and nutrition are not considered that important, nor social difference, whether sort of gender, age, ethnicity, etc. So we're going to close this now, and yeah, so thanks very much for all of that sort of survey, and then I'm going to move on and introduce our first speaker. Our first speaker is Dr. Nkechi Owoo. She's from the Department of Economics at the University of Ghana. She's also a research associate at the African Centre of Excellence on Inequality Research and a senior research fellow at the Environment for Development Institute. So she works on spatial econometrics in addition to microeconomic issues in developing countries across a range of issues that are relevant to this workshop: household behavior, health, agriculture, gender issues, and demographic economics. So her talk is going to be on poverty and inequality and health issues in Ghana. And Nkechi, perhaps I could ask you now to take over and proceed with your presentation. Thank you very much.
Thank you very much, Mark. So I'm sharing my screen now. I hope everybody can see. Okay.
It's coming through fine.
Okay, thank you very much. So I'm pleased to be presenting on our topic, multidimensional poverty and health inequalities in Ghana. Now, this is a paper that's been prepared by myself and Professor Robert ACEIR, both from the African Centre of Excellence for Research Inequality, based at the University of Ghana. This is the outline that my presentation will take. Now, the evidence on social gradient in health is very well documented. Now, this refers to a situation where people who are more disadvantaged with respect to their income status have worse outcomes than those who are less disadvantaged. Now, there's this increasing concern about these income-related health disparities growing over time and in many different countries as well. And it is prompting some concerns about the need for designing appropriate policy interventions to try to mitigate poverty and corresponding health inequalities in these different countries. Now, a lot of research has focused on this link between poverty and then health, and these have tended to proxy poverty using monetary metrics. And now there's a number of channels or reasons why we might expect monetary poverty to affect health. So for example, the poor may not be able to afford adequate healthcare, if any. They are also likely to be malnourished because they can't afford to buy food. The poor are also likely to reside in places that are far away from trained physicians and well-equipped hospitals. The poor may also reside in congested slum-like areas, which increase the risk of diseases, for example. Studies that have looked at this health poverty link indeed have found a negative relationship between monetary poverty and then health. However, the focus seems to be shifting away from using monetary metrics or a unidimensional measure of poverty to more multidimensional poverty indicators. Now, multidimensional poverty indicators tend to incorporate a lot more of the deprivations that are experienced by poor people in their daily lives. So we're talking about things like limited access to food, poor nutrition, lack of education, inadequate living conditions, among others. Now, there have been some studies that have looked at how health is associated with non-monetary, multidimensional poverty in the Ghanaian context. And recent work has been done by Ejiri and others, where they looked at the relationship between child multidimensional poverty and then women's health outcomes in Ghana. Now, interestingly, Ghana's first multidimensional poverty index was introduced last year in 2020, and it comprises, it's constructed using 12 non-monetary indicators across 3 different dimensions. So we're talking about education, health, and then living standards. And these were selected to reflect the needs and then the priorities of individuals within the country. Now, early analysis of this index revealed, interestingly, that the national incidence of non-monetary poverty is almost twice the incidence of monetary poverty. And this suggests that there's a state of unequal and differing access to basic survival needs and public services across different groups within the country. The use of multidimensional poverty indicators is also great because it provides better information to policymakers on the types of deprivations being experienced by Ghanaians, and hopefully better equips them to be able to provide, better targeted solutions to the goal of mitigating poverty within the country. Now, in our paper, we look at three research objectives. First, we explore subgroup differentials in multidimensional poverty, looking at different groups of people. So looking by rural-urban residents, by the gender of the household head, education status, and also we look at the differentials in multidimensional poverty across the 10 regions of the country. A second objective that we pursue in this research is to examine bivariate correlations between multidimensional poverty and a series of selected health indicators that I'll talk about shortly. And then finally, we use different regression model specifications to try to explore robust correlations in the relationship between multidimensional poverty and health outcomes in Ghana, but now controlling for a host of potentially confounding variables. Now, to explore our research objectives, we incorporate data from the third wave of the Ghana Socioeconomic Panel Survey that was collected in 2018-2019. Now, this is a nationally representative data set. It includes over 5,000 households and close to 19,000 household members. Now, this data set is ideal for our study purposes because not only does it have all of the variables that we need for the analysis, but it also includes all of the data on the dimensions and indicators that have been specified in the Ghana Statistical Services report for calculating Ghana's country-specific multidimensional poverty index. Now on this slide, I'm showing an excerpt from that GSS report just to give an idea as to how this multidimensional poverty index is constructed. So it deals, as I mentioned earlier on, with 3 dimensions, so living standards, education, and health. And for each of these dimensions, we have a number of indicators. Now, a household, we also have the conditions for deprivation. Now, what this means is these are the conditions that will determine whether a household is deprived or not in any of these indicators. So for example, if you take an indicator like water, a household would be classified as being deprived if its drinking water is from an unclean source, and so on and so forth. So in our paper, we actually come up with 3 different measures of multidimensional poverty. Now, the first is simply a weighted sum of the deprivations for each household in the table that I showed before. And here we actually weight all of the indicators equally. So our final poverty index is sort of an average poverty score for each household based on which of these indicators they are deprived in. So we have an index between 0 and 1 with higher scores indicating greater levels of multidimensional poverty. Now, with respect to our second indicator, what we do is to use the information from the poverty index to sort of reclassify households into 4 mutually exclusive poverty categories, using, again, nationally prescribed cutoffs. So a household that has a poverty index less than 0.2 is classified as being not multidimensionally poor. Households with indices between 0.2 and 0.3 are classified as being vulnerable to poverty, and scores between 0.33 and 0.5 would mean that the household is multidimensionally poor, while scores greater than 0.5 indicate severe multidimensional poverty within these households. And then finally, the third measure of multidimensional poverty, what we're calling the poverty intensity, simply adds up the different indicators that a household is deprived in. So as I showed on the table before, in Ghana, we have 12 indicators that make up our index. So a household can be vulnerable in none of them, or be vulnerable in as many as 12 of them. So of course, the greater the number of indicators that a household is deprived in, the greater the poverty intensity. So these are the 3 measures of multidimensional poverty that we will be using for this research. I'd also like to talk a little bit about some of the health indicators that we use as well. So we're going to use about 4 for our research purposes. The first a dummy variable coded as 0 or 1, depending on whether any household member reports that they were ill in the 12 months preceding the survey. So an affirmative response is coded as 1, and if no household member has been ill, that household is given a code of 0. There's also information on household members' self-reported health. So whether or not household members felt that they were very healthy, somewhat unhealthy, or unhealthy. And again, we code unhealthy responses as 1, healthy responses as 0. We also include a proxy for women's health in this paper. So using the number of children ever born, because the literature suggests that higher fertility among women is often indicative of poorer health. So we also incorporate this variable as well, which is a count variable. This will be important later on when I talk about the regression specifications that we employ. And then finally, we have a proxy for mental health, or a household's depression status, if you will. Now, the Ghana Socioeconomic Panel survey asked about 10 questions to respondents about their emotional stress. And each comes with a 5-level response scale. And now, consistent with the Kessler psychological distress scale, we take all of these responses and then we sort of add them up. So we have scores for each individual and for households at the average between 10 and 50. Now, lower scores are indicative of lower emotional stress. And then what we do with these scores is following the Victoria Population Survey of 2001, we reclassify these scores into 4, again, mutually exclusive depression statuses for households. So we can have a household that has no depression, mild depression, moderate depression, or severe depression based on their responses to these questions about their mental health. Now, when I talked about our research objectives, the third one is to explore the relationship between multidimensional poverty and health, and while we control for a host of other variables. And on this slide, I'm showing some of the explanatory variables that we incorporate in this research. So we control for things such as education, employment, age, marital status, religion, among others in this paper. Now, with respect to the methodology that we adopt, we use descriptive statistics and then also multivariate regression models. Now, the descriptive statistics are useful when we talk about subgroup differentials in multidimensional poverty. And we also use graphs to sort of highlight bivariate relationships between health status and then multidimensional poverty. Now, with our third research objective, we'll be employing a series of multivariate regression models. And as you can see here, we have quite a few specifications depending on the nature of the dependent variable, our health indicator that I talked about earlier on. Now, when the health indicator is illness or self-reported health, as I showed, these responses tend to be binary. And so we employ a logistic regression model, and later on you'll see we report odds ratios. Now, for the health indicator, the number of children ever born, the proxy for women's health, we employ a negative binomial regression model because of the count nature of the data. We did run some tests and we found that this is more appropriate than the Poisson regression model. And then for the regressions relating to households' mental health or the depression categories, because these are 4 mutually exclusive variables, we employ a multinomial logistic regression model. So we are concerned about the likelihood of reverse causality that could plague this study. So there was a paper by Benzaval and Judge in 2001 where they reviewed several studies, and they showed that predominantly when we talk about the health poverty relationship, the causal relationship is more frequently from poverty to poor health, and reverse causation is not such a serious problem. Additionally, although it is clear that health may affect monetary poverty, it's not as straightforward to assume that health would affect certain non-monetary indicators like access to electricity, cooking fuels, among others, which make up the MDPI. But nonetheless, what we try to do in this paper is to present a series of robust correlations that are aimed at exploring the relationship between multidimensional poverty and then health outcomes in Ghana. And now I'd like to sort of show the first set of results looking at subgroup differentials in multidimensional poverty, in the Multidimensional Poverty Index for Ghana. And the first slide that I'm showing is looking at these differences between rural and then urban households. I'm focusing on our first poverty measure, just the poverty index. So now we see that multidimensional poverty appears to be higher in rural compared to urban areas, and these differences are highly significant. When we look at what's going on between multidimensional poverty and in education, we see that we have lower poverty scores at higher levels of education, and then as the level of education drops, we tend to see higher poverty scores. So indeed, multidimensional poverty appears to be lower among more or better educated households. We also look at a multidimensional poverty between male-headed and then female-headed households. And we find that on average, the poverty index is greater in male-headed households compared to female-headed households. And although the difference may seem small, it is highly significant at 1%. And then finally, we look at the distribution of multidimensional poverty across the 10 regions of Ghana. And we find out that regions like the Upper West and Northern regions have higher poverty indices compared to a place like the Greater Accra region, which has the lowest poverty index, and then followed by the Ashanti region. So to summarize, we did find higher poverty indices for rural, less educated, male-headed households, and also households that are based in the northern and then upper west regions of the country. In the presentation, I'm showing the results for the poverty index, but in the paper, we sort of repeat the exercise using other measures of poverty, like the poverty intensity, and these results are consistent. So these results suggest that there are substantial differences in access to basic amenities and then public services across different groups in Ghana. So there are things like unequal access to safe sanitation, clean water, access to electricity, national health insurance, among others. And then these would certainly need to be addressed in order to reduce these differences in multidimensional poverty across the different groups. At this point, I'd like to also present some bivariate relationships between our indicators of health and, again, multidimensional poverty in the Ghanaian context. So in this first slide, we're looking at the relationship between multidimensional poverty and depression. And we notice that poverty appears to be correlated with poorer mental health. So our poverty indices appear to be higher in households that are characterized by more severe depression compared to those that have no depression at all. We also look at the relationship between multidimensional poverty and illness. And again, we see that poverty is correlated with illness. So it tends to be higher in households who have had poorer health in the past year leading up to the survey. And these differences, again, are highly significant. When we look at the relationship between multidimensional poverty and self-reported health, we see that poverty again is correlated with worse self-reported health. So we see that it's higher among those households who report that their health is generally bad. And these differences are significant. And then finally, we look at the relationship between multidimensional poverty and our proxy for women's health. That's the number of children that they have ever had. And we find again that poverty is correlated with having more children. And of course, this suggests negative implications for the health status of women and their children. So to summarize, we see a clear negative association between multidimensional poverty and health. And again, when we use other measures of poverty, these relationships are still found. However, in order to more clearly isolate the contribution of multidimensional poverty to health outcomes, what we do in the paper is to use a series of regression analyses controlling for potentially confounding factors to see if we can get a clearer idea of the relationship between these two variables. And at this point, I'd like to share some of the regression results that we have had. So on this slide, we're focusing on our first measure of poverty, the poverty index, and I talked about how this was constructed. So what we do is to regress each of our health indicators, so depression, self-reported health, illness in the past 12 months, and also women's fertility on our main variable, independent variable of interest. And we include all of the controls that we talked about or that I showed on that table, and these are all contained in the full paper. So I'd like to go straight into the results that we're finding. So first of all, we're finding that higher poverty appears to be correlated with increased odds or higher odds of mild and then severe depression. We also find that higher poverty is associated with higher odds of household members reporting that they have poor health or they have been ill in the past 12 months leading up to the survey. And then finally, higher poverty appears to be associated with higher fertility and therefore worse women's health in the Ghanaian context. On this slide, I'm showing the results from our second construction of multidimensional poverty, where households are classified as being either not multidimensionally poor, vulnerable to poverty, multidimensionally poor, or being severely multidimensionally poor. And we're using not poor as sort of the base category here. Now, looking at the series of results, we find that households that are vulnerable to poverty and who are multidimensionally poor tend to have higher odds of being moderately depressed, while those households who are poor also have higher odds of being severely depressed, although these results are only marginally significant. We also find that as the poverty classifications increase, at least compared to households who are not poor, all other households are associated with the reporting of poor health by household members. We find also that there's consistent increases in women's fertility levels with higher degrees of multidimensional poverty. And with respect to the last series of results, this time we're using our third poverty measure, the poverty intensity. So that is, just as a reminder, the number of indicators that households are vulnerable in, which ranges from 0 to 12. And here, what we find is that higher poverty intensity is associated with severe depression, and is also associated with higher odds of household members reporting that themselves that they are in poor health, household members being ill in the past year, and also associated with higher fertility and therefore poorer health among women. So just to summarize again the result of our regression analyses, we see a sustained negative association between multidimensional poverty and then health, controlling for a host of other variables. Now, this finding of higher odds and experiences of poor health among those who are multidimensionally poor is consistent with existing work that has been done, but predominantly in developed country context. So to summarize, we find that poorer households generally had higher odds of experiencing mental health challenges like depression. They demonstrated higher odds of self-reporting poor health. We also found from our results that households that were multidimensionally poor also had higher odds of having been ill in the 12 months prior to the survey. And then finally, there was a clear positive association between households that are poor and women's fertility levels. So to conclude, it's examining the links between poverty and health certainly is very important, given the current economic trends and growing inequality that we see happening within the country. These might be expected to further exacerbate already existing health differences within the country. The results from this research are critical for the identification and creation of effective interventions that should reflect the development needs of Ghanaians. We found that multidimensional poverty is correlated with worse health outcomes, and therefore access to amenities and other social interventions, it appears, vary widely across the country. This may be translating to differences in the distribution of multidimensional poverty, and finally leading to health inequalities with implications for welfare. These disparities or differences would need to be addressed in order to maximize well-being of Ghanaians and also achieve equitable and inclusive growth within the country. Now, I think that future work, it would be useful to sort of use panel data to try to explore these links between health and then MDPI, because it would help to tackle any potential concerns or lingering concerns of endogeneity with studies that use cross-sectional data. It's important to notice that even though we find that multidimensional poverty does have effects on health, the exact pathways that this happens is not too clear. Existing research, as I mentioned, have used unidimensional measures like maybe just nutrition or just education. But when we use a multidimensional indicator like this, it's difficult to see the specific channel. So are particular indicators more important, for example, for particular health outcomes? And then also it may be important to vary the weights that are applied for particular indicators. As I mentioned before, in Ghana, we have 12 indicators, and in generating the poverty index, we weight each of these indicators equally. So for example, would it be useful to vary these? Is access to health insurance, for example, more important than housing conditions in explaining a multidimensional poverty and therefore health outcomes? And then another thing that we don't do, but I think future research should look at, is to explore the presence of interaction, significant interaction effects. So for example, is the strength of the relationship between health and multidimensional poverty dependent, or would it vary by characteristics like gender, marital status, among others? So these are things that future work may want to explore. So thank you very much for your attention, and I look forward to your questions, if any. Thank you.
Nkechi, thanks very much for that comprehensive talk. We've got about 10 minutes for questions, and what I'm going to ask people to do is really ask questions of clarity or questions that have been stimulated by the talk that Nkechi has given, rather than giving your own opinions or examples from your own areas, because that's really where we're going to be working on in the breakout groups. So please do raise your hands if you have any questions. While that's happening, Nkechi, I just wanted to ask you a question here. From what I could see there, I didn't see any information on whether any of these indicators are changing over time. Maybe I missed it, but I wondered what the trends were in some of these predictors, and then also the health outcomes, whether we were heading in a direction where those predictors were going to become more severe, and whether the outcomes and the health outcomes, whether there's any trend in those. So perhaps you could answer that one while we wait for other people to come up with some questions. Yeah.
All right. Thank you very much, Mark, for this question. So I will say that in this paper, we haven't looked at the analysis with the trends yet using the Ghana Socioeconomic Panel Survey, but there is data using information using the Ghana Living Standard Survey that shows that actually multidimensional poverty appears to be increasing over time. And then we know that generally health outcomes also may be showing a similar trend. But yes, we do look forward to sort of, re-exploring these relationships using the Ghana Socioeconomic Panel, because we do have access to 3 waves. But then this is, with respect to the Ghana context, it's still relevant to know that, yes, it appears to have been increasing over time. So there's a genuine concern there.
No, so we're in the wrong direction of travel at the moment in Ghana.
It would appear so.
The 3 waves of data. Okay, thanks. So Darlington, do you want to ask a question?
Okay, thank you, Nkechi, for the presentation. I just wanted you to clarify is it one of your indicators for the women's health and higher fertility? I really didn't get it very well in terms of how then does it relate to poverty and all that. Yeah, thank you.
Thank you very much for your question. So with this paper, we're looking at measures of the links between health and then poverty. So, so we're looking to see whether multidimensional poverty leads to worsening health, for example. So what we wanted to do was to have different measures of health. So we have, let's say, illness in the past year. We have self-reported health. We also had a measure for mental health. Now, the fertility is used to proxy women's health. Okay, so it's simply saying that, so for example, if a woman has a lot of children, because of the stress that may happen to her body, it could lead to worsening health outcomes for her. So this is sort of where that variable comes in. It's a proxy for women's health. A higher level of fertility would suggest that women are not doing too well health-wise. So at least according to the existing literature. So that's sort of why we incorporate this health indicator as well.
That answers your question, Darlington.
Yeah, she did. Thank you.
Thank you very much for the question. Please, I think there are a few questions in the chat box as well.
Yeah, I've been looking at them. So, Nkechi, maybe the question from Rejoice in terms of measurement error with the self-reported health variables. Do you account for that?
So with the self-reported health variables, these are subjective measures of health that are present in the data. So as I said, we have responses. We just have 4 different options for responding. So whether household members are very unhealthy or unhealthy, whether they are healthy or not healthy. So what we did was to simply recode into a binary variable. So if you said you are unhealthy, we gave you a value of 1, and if you said that you were healthy, we gave a value of 0. So this is simply the way that we coded this variable with our data set or with the analysis.
Maybe the question is also around how do you know that you've got consistent self-assessments? Because presumably people interpret that question differently when you're doing your enumeration. Yeah.
That's very true. And even when you think about self-reported health as well, sometimes it even depends on exactly what type of a mood the person is in when they are responding to these questions. We are aware of some of the challenges of using some of these health indicators, but just to try to be consistent with some of the research that's been done out there, we wanted to incorporate this as well. And this is why we use a number of different indicators as well. So even if that variable, as we know, can be problematic, we do have other ones, that health indicators that we lean on to try to get at, some robust story that we can tell, even if, we have some health indicators that can be classified as being a little problematic. Yes, but it has benefits also because, you know the arguments that sometimes, even if you say a person isn't doing well with respect to their health, maybe subjectively they think that, no, it's not too bad, I'm actually fine. So there are pros and cons for using this variable, but yes, we are aware of the limitations, yes.
And then, sorry, there's a question from, sorry, just scrolling through, from James. James, perhaps you could just verbalize your question because I didn't quite understand what you meant in the chat. So maybe you could just, if you do have a microphone, just quickly repeat the question and to give a bit of better clarity there. Yeah.
Morning. Hello, Nkechi. Thanks for your talk. Hello.
Yes, hello. We can hear you.
Go ahead.
Do you hear me?
Yes.
I'm really educated in the topic, and just to outline, just put it out there that I'm quite a novice in this area. So I was trying to get clarity there because I look at the indicators. You talked of self-reported health, and there is illness as well. So I wanted to know what's the difference between the two, because to me, they seem to say the same thing.
Thank you very much. So I think one of them is simply stating, one of them I think may be more objective. So the question in the data set is, in the past 12 months, have you ever been ill, right? So it's whether, you have felt unwell. Now, even though this could be correlated with you declaring how healthy you feel, sometimes the responses can differ, right? So you can have somebody who has maybe had malaria, maybe once or twice in the past year, but when you ask him, so generally, how would you rate your health? Such a person may tell you, oh, I think I'm healthy. Yes, I was ill once, but I think I'm healthy, right? And you can have somebody who hasn't been ill or hasn't visited the clinic even once, but you can have people who believe, oh, well, because I haven't had a checkup recently, you know, I feel as if I could be unhealthy. You never know, you know, because I work in a place maybe where, you know, there's, you know, hazardous fumes or whatever. So one of them is stating, okay, what exactly happened in the past year? The other one, as I said before, is more subjective. It's saying, how do you feel about your own health? Do you think you are healthy or not? Sometimes you'd expect the results to agree, but sometimes too, depending on, as I said before, how a person feels when they are responding to the question on self-reported health, we can have different responses from their actual experience of illness in the past 12 months. I hope this is a little clearer.
Yeah, thanks so much.
Thank you too.
See, let me go ahead. Sorry, I was muted there. Terry, thanks for your question, but I think that's something we're going to discuss in a bit more detail in the breakout groups. And as we're coming to the end of our slot, could you hold that question you have for the breakout group? And obviously everybody else as well. We now need to move on to the next presentation, which is James Irlam. James is a lecturer at the University of Cape Town working in the health sciences. He's involved in teaching on a master's program that includes issues around public health and the environment, including climate change, and has also been involved in quite a bit of research looking at the linkages between health and climate change in the South African and other contexts. So James, do you want to go ahead and share your screen? I presume you've got a presentation, and yeah, over to you. Thank you.
Thank you, Mark, and good morning, everyone from Cape Town. And I will certainly share my screen and in the next 20 minutes try to just give you an overview of some of the interconnections between climate change and health. I trust you can all see that now, and I'm just going to open that in slideshow mode.
So go ahead and go for it. Yeah.
Okay, good. So thank you very much. I'm a senior lecturer within the University of Cape Town Faculty of Health Sciences. I usually teach climate change and health to public health students at undergraduate and postgraduate level. And the outline of my presentations are normally moving from the evidence of climate change and how that impacts on the determinants of health and the particular climate health impacts, to looking at what health professionals can do as change agents. And particularly in the era of COVID, we've seen health professionals on the front line of the of the pandemic response. And likewise, we're starting to see them increasingly on the front lines of the climate change response. So back in 2008, the then Director General of the World Health Organization identified climate change as one of the greatest challenges of our time, affecting some of the most fundamental determinants of health, food, air, and water. The following year, the Lancet Commission on Climate Change and Health published this landmark report, which identified climate change as the biggest global health threat of the 21st century. And when we think about health, we think about it and teach it in a very holistic sense. So you can see in this figure the many determinants of health and well-being categorized into 7 layers, with climate change and the global ecosystem exerting an impact on all the other determinants by many different pathways that vary by region and people group. So when we speak about the environmental and social determinants of health, we also recognize that they are tightly linked with equity and social inequalities, particularly in a country like South Africa and in a continent like Africa. The Lancet Commission in that 2009 report spoke of health as the bottom line of climate change, and of how we have multiple pathways that run from the heating of the atmosphere through global greenhouse gas emissions. We have ocean acidification. We have raised temperatures, altering rainfall patterns, sea level rise, extreme weather, and other pollutants, all of which have an impact. Sorry, let's just go back to that. All of which have an impact in multiple ways on the health conditions: undernutrition, impact on mental health, cardiovascular disease, respiratory disease, harmful algal blooms, and vector-borne diseases. And the pathways are through heat, through flooding, through drought, through fires, through loss of biodiversity and ecosystem change, increases in air pollution that drive more heating and extreme pollution events. The CDC has produced this useful conceptual map, which shows how the increasing CO2 levels, rising sea levels, extreme weather events, and rising temperatures impact on the environmental determinants of health, air pollution, vector ecology, water and food quality, extreme heat, severe weather, and each of those impacts on health in particular ways. So to take extreme heat as an example, we're seeing, as we'll see, more and more heat waves of extreme hot temperatures, leading to heat-related illness and death and cardiovascular failure. And when you combine that with urban heating and with air pollution from transport and from industry and coal-fired power stations, you have the horrendous situation like you're seeing in cities like Lahore and Delhi in India at the moment, where a combination of industrial and agricultural pollution and transport has created a massive increase in the number of people presenting to hospitals with respiratory conditions, and those who are particularly vulnerable are the elderly and those living with comorbid conditions. So one could take any one of these set of health outcomes and look in more detail at the pathways, but we'll focus on some of them that are more particular to Africa. The Lancet Countdown is a worldwide collaboration for tracking progress on health and climate change, and there's a helpful YouTube clip based on their most recent report, which obviously in the light of the COVID pandemic spoke about these two converging crises, and the statement highlighted there that unless the global COVID-19 recovery is aligned with the response to climate change, the world will fail to meet the targets laid out in the Paris Climate Agreement, damaging public health in the short term and the long term. The WHO produced this manifesto for a healthy recovery from COVID-19 to address the root causes of the pandemic and to prescribe specific measures to prevent such pandemics becoming more frequent and more severe in future. And these measures include safeguarding a healthy and natural environment as a foundation of good health and well-being, ensuring universal access to clean water, transitioning from fossil fuels to renewable energy, and that's a particular issue in a coal-dependent country like South Africa, promoting healthy, sustainable food systems and more plant-based diets, building livable cities with more public transport, active mobility, reduced air pollution and heating, and then stopping the taxpayer funding of pollution by means of huge subsidies for fossil fuels. And that's become a real issue of focus at the most recent COP and the moves to phase out coal for energy production. So the IPCC report was a code red for humanity, according to the UN chief, and we've seen in recent months the terrible wildfires. We're aware of the growing air pollution in cities around the world, including our own in Mpumalanga province of South Africa, where all our coal-fired power stations are. And some of the headlines of this 6th assessment report were around the increasing heat waves, longer, warmer and shorter cold seasons, intensifying water cycles, so more intense rainfall and flooding and intense droughts, increasing precipitation and changes in rainfall patterns, sea level rise and the threat to many coastal cities in southern Africa, snow and ice, the melting of the Arctic and Antarctic, and then within Africa, glaciers on Mount Kilimanjaro and other mountains that are significant sources of fresh water. Changes to the ocean, so warming and acidification, and then the urban heat islands that we see as a result of the heating effect of buildings and tarmac in cities around the world, in a world that is becoming increasingly urbanized. So the State of the Climate in Africa report is an annual report that this was published in October 2021. We're looking at the state of climate in Africa in 2020, and it warns about the longer, warmer seasons and shorter, colder periods, increasing heat waves, undermining food security, and posing risk to millions of lives in Africa. And the fact that in Africa, global warming is happening faster than other regions in the world. And by 2030, up to 118 million extremely poor people will be subject to the devastating impacts of drought and intense heat. And so this piece in the conversation was written by a member of the Chance Network, which I'll tell you a bit about, but it essentially explains how the heat waves affect people and why this is a particular risk in Africa. As temperatures rise, there's also an increased spread of infectious diseases such as malaria and dengue fever, spread by mosquitoes, and also droughts leading to longer crop failures and subsequent under and malnutrition in a continent that is already food insecure. So by 2100, it's expected that there'll be an increase in prevalence of wasting in Western Africa by 37% and 25% for Central and Eastern Africa. And then this slide just focuses on some of the vulnerabilities of women. So in the first excerpt, the vulnerability to climate change and variability in Mali was particular amongst women, and yet it highlights the fact that even though their vulnerability is increasing in the short term, over the long term, the emerging changes in women's roles could lead to positive impacts. The second article just highlights that with the impacts of climate change intensifying, that there's a great need to build more resilient health systems, and particularly to promote gender-sensitive health and climate adaptation responses, given the differential impacts on women and children. These two articles just speak about the particular vulnerability of people living in informal settlements, which are growing around cities in Africa, and highlighting the paucity of original research and solid study designs. This mixed method case study from Dar es Salaam just highlighted the numerous factors that increase the heat health vulnerability of informal settlement residents. So the type of building materials, the poor water and sanitation services, and lack of access to health services, and the need for, again, better research to inform adaptation methods for vulnerable groups like this. And then this literature review of the impacts of heat stress on human health across Africa, which was published in April, identified key opportunities that can benefit Africa through the expansion of the scope of heat stress and human health research. And some of the research gaps highlighted there are vulnerability assessments within demographic classes, such as the elderly and children who are most at risk, personal exposure and associated risks, the urban heat island effect that I've spoken about, and heat adaptation research to enable informed and targeted preventive action, and the need for transdisciplinary research that is supported by local, regional, and international collaboration. And I'll give you an example of that a bit later. And then here is a policy brief that came out of work I was involved with back in 2018 to inform the update of the Western Cape Climate Change Response Strategy, which is a response strategy for the province where I'm located. And it highlighted some of the expected impacts of climate change in terms of increased average temperature and frequency of hot days in the province, increased drought events and intense rainfall events, rising sea levels and increasing ocean temperatures, and then the increased chance of fire events. So wildfires are a common feature of the hot and windy summer in the Western Cape, and those are predicted to become more intense, worsening air pollution and obviously displacing agricultural workers. And the drought that we saw in 2017, 2018 saw a massive migration of agricultural workers to informal settlements. All of this has impacts on the burden of disease, and we've highlighted there some of the particular impacts of these climate change effects on interpersonal violence. So we've seen that with gender-based violence already being endemic in many parts of our society. TB, which is a pandemic in the Western Cape and goes along with HIV across South Africa. People living with heart disease, respiratory infections are at particular risk of heat and air pollution. And the vulnerable populations are those demographic and occupational subgroups. And so as a result of that research and extensive literature review, which was published there, and you can see the link, we identified some of the additional research gaps and recommendations about including further research for the Western Cape and for its monitoring and evaluation systems. The current Western Cape Climate Change Response Strategy is out for public comment, and so for those of you who are resident in this part of Africa, there's an opportunity to engage with the update via workshop in January. And then turning to some of the ways in which health workers can be agents of change. So I've highlighted the particular risk groups, and the things we talk about to our students are around phasing out fossil fuels in favor of clean and renewable energy, working for efficient and healthier buildings, those more sustainable food systems and more plant-based diets, and then active transport. So walking and cycling and improving public transport to reduce urban heating and air pollution, and also to promote the co-benefit of healthier individuals. And then actions from the health sector. So health professionals have real agency, and we try and convey that to our students, how they can use their voice to speak out on climate change and to be part of the health decision making, getting health into policy around energy, around the environment. And we saw this particularly at COP, how ahead of COP26, there was a massive mobilization of health professionals around the world. They came up with this healthy climate prescription, which was an urgent call to the leaders around how to improve their climate commitments to restrict warming to 1.5 degrees, with health and equity at the heart of those nationally determined contributions. And then also looking at pandemic recovery instruments that support climate action and reduce social and health inequalities, and looking at how to reduce the environmental footprint and carbon footprint of healthcare services themselves. So through a group called the Global Climate and Health Alliance, we were part of raising the voice of the health community at the COP26 conference. And ahead of that, we had done work on making our nationally determined contribution from South Africa more cognizant of health. And so the Global Climate and Health Alliance had this Healthy NDC scorecard that gave points to the commitments from each country. So South Africa scored pretty well on integrating health into its commitment. But of course, the challenge now is to follow up on the whether that commitment translates into meaningful policy and practice. And then through a group called the Public Health Association of South Africa, Climate, Energy and Health Special Interest Group, we gave particular amplification to the messages of the Health and Climate Network around energy systems that protect climate and health, calling for the just transition to sustainable energy, the ending of fossil fuels, putting health at the heart of our climate policy and action, as I've just explained, and then also looking to reduce the indoor air pollution from unhealthy cooking technologies, which contributes hugely to the burden of respiratory disease and death in a country like South Africa and across the continent. I think the COP26 special report on climate change and health was shared with you prior to this workshop. So it's well worth reading for the way in which it frames climate change and the climate emergency as a health emergency, but also as an opportunity to mobilize the health sector as an opportunity to build these climate resilient and low carbon health systems, as well as energy systems, food systems, healthier cities. So again, building on the COVID pandemic recovery prescriptions of the WHO from May last year. And then GGHH stands for the Global Green and Healthy Hospitals Initiative of Healthcare Without Harm, which recognizes that healthcare systems themselves are major contributors to global heating and environmental pollution through chemicals, through procurement, through energy, water, and waste. And so they've come up with this 10 item agenda for action on improving the sustainability of health services. And we've been part of efforts to make hospitals in South Africa align with the goals and to sign up to the Global Green and Healthy Hospital Network. And that is something that is been growing worldwide quite spectacularly over the last decade. And then I just want to end with the announcement about this new network, the on climate, the Chance Network for Climate and Health Adaptation in Africa, funded by the EU Horizon 2020 project. And it held its first meeting in September, and some of the focus areas are heat, air pollution, and infectious diseases in Africa. And it's an opportunity to network and develop synergies in East and Southern Africa to facilitate knowledge exchanges, learning and cooperation, and to provide technical support for national and regional applications for funding of program activities and research. So if this is something that you're interested in, to sign up. please let me know, and we'll also invite you to the workshop on heat and heat stress in Africa, which will be held, I think, on the 1st of December. Okay, so with that, I'll stop sharing and happy to take any questions.
Thanks very much, James. That was a real tour de force through climate change and health issues. So again, please, any questions of sort of things that you'd like clarified or thoughts that have been stimulated, that'll be great. We've got just under 10 minutes for that. James, I wanted to start with a question from me, which is, I can't remember whether this is something that was said to me by authors of the health chapter in the current IPCC process or coming out of the last IPCC report, but their sort of biggest action point in terms of responding to climate change risks on health was saying basically improve health systems. So nothing really specific around specific actions, but that, you know, the biggest vulnerability that or channel through which climate change impacts on health is through health systems that are just not working very well, even without climate change. And I think we sort of experienced some of that maybe in different settings during the COVID pandemic. But I was just wondering if you agreed with that, but then secondly, whether you thought there were any particular aspects of kind of if you imagine like the Western Cape health system being perfect, then what else would it need to do to continue to be sort of fit for purpose in a changing climate? Are there any areas of action that a well-functioning health system should be concentrating on over and above getting itself to be functioning well, if that makes sense?
So yes, I would certainly agree, and I'll just go back to the agenda of the, you can see that, right? There we are, the Global Green and Healthy Hospital Agenda. Priority focus areas of hospitals that have signed up to that agenda have been, you know, to reduce energy use, to minimize waste. Certainly in the drought we saw water saving. You know, all of these are huge impacts on the environment from the health system. It's been estimated that the healthcare sector contributes, I think if it were a country, it would be the 5th largest emitter on the planet. And so ways of mitigating climate change in those areas are important, and then also adapting the health system to cope with the increased climate health impacts that we're going to see. I mentioned the example in India and Pakistan of air pollution. So what can healthcare professionals do to lobby for improved air quality standards, and what can they do to make sure that hospitals are able to deal with the growing impact of air pollution on health? The COVID pandemic highlighted the underpreparedness of many health systems. They highlighted also the huge impact of plastic waste and from healthcare systems on the environment. So there is a move to decarbonize healthcare systems by 2030 in the NHS, by 2050 in many other countries, and you know, there is a pathway that's been identified for doing that. So yes, I would certainly agree that healthcare systems improving their resilience, ensuring that they are low carbon, are a very important response to the climate crisis and an opportunity for greater investment in health in the future, particularly given the vulnerabilities of women and children, as I mentioned, and of people in informal settlements. So making sure that our healthcare systems are able to meet the needs of those vulnerable groups.
So we've got a couple of hands up and then a few questions in the chat. So Christian, I think it's Christian, you had your hand up, and then after that, Janine. So maybe we can take both questions from Christian and Janine in turn, and then James, you can try and answer them in one go.
Okay.
Okay, thank you so much. Such a brilliant presentation, James. I think I got just part of the answer from the, when you start responding to Mark, that we need to do, the health professionals need to see how they can bring healthy and green hospitals. But I just want to know, what are your thoughts in promoting behavioral change from the student as we're teaching them, giving them knowledge on climate change and health, but we also need to try to see how we can transform or bring some of the input that can lead them to a behavior change, so that they become the really activists of climate change, and that can lead to a clear transformation of the society. Thank you.
No, it's a great question. So behavior change is one of those very difficult things to get right. It's health promotion and behavior change is one of the things that we teach students, and it starts again with the holistic view of health. You know, I referred to the determinants of health at the beginning. So how does one create the conditions that are conducive to better health? So we need action upstream on the natural environment, on the urban environment, in policy, within hospitals. And then we also need to teach, you know, within our healthcare institutions, we need to model that. So Christian is from Stellenbosch University, which has set a good example for the rest of the country in terms of prioritizing environmental sustainability through the Dean's Advisory Committee, through greening initiatives on campus. At UCT Health Sciences, we still have a way to go in terms of role modeling that. Yeah, behavior change, making the right choice the easier choice. So, you know, if we want cities that are healthy and more livable, we need to prioritize public transport and active mobility. And that might mean disincentivizing people bringing, you know, using their cars for transport. And then it's teaching the skills of health education that are part of patient consultations. So helping patients see the co-benefits of adopting healthier lifestyles. So for example, growing their own food reduces the carbon footprint of the food that they buy, and also is promoting healthy activity and healthier food for them. Getting them to walk or cycle more has the co-benefits of reducing pollution and, you know, improving their cardiorespiratory health. Yeah, and there are principles of effective climate change communication that include using plain language, not jargon, finding out what people already know about climate change, and ways that they can identify in their context for making behavior change easier. Yeah, there's a whole psychology of climate change communication, but essentially it's founded on the principles of an open discussion, climate scientists being able to convey the linkages between what's happening at a global ecosystem scale through the pathways of those determinants of health to where the patient is and where the health system is at this point in time. Janine?
Thanks. Janine, do you want to go ahead quickly? We've got a few minutes and then we're going to have to close down the discussion. So everybody else, please keep your questions for the breakout groups.
All right, thank you very much, and my greetings to everyone. And I would like to congratulate you know, Mark and the entire team. I joined a little bit late, but due to other commitment. But this is very interesting, exciting talk, but very complex. in a sense, myself as a scientist, a researcher, public health specialist, it becomes difficult to comprehend or to be able to define in a very simplistic way the nexus of these three key areas. We're talking about climate change, health system, as well as inequality and poverty. But particularly my question here, should we, in a very, very simplistic way, on the African continent, focusing first on the African continent as African institutions and African, is there any study that, or some knowledge somehow one could borrow to try to understand on the effects, of climate change, or when there is yes somehow an intertwine of these three different, be climate change, poverty, and health. But I think it's not a linear kind of a relationship, or kind of a, if you want to establish a causality, but more of trying to understand how, how do we quantify to know what is the contribution of the health system towards climate change? Talking about determinant of health as well, poverty and equality, what is the contribution in a very quantifiable way or very simplistic manner, so that it kind of be easy for, even for the researcher, even as well for healthcare professionals to understand, because I feel like it's very complex. Health system on itself, it's complex. Now adding these other elements, then it becomes even more complex. And we know that as healthcare or health system alone is not about healthcare workers. Climate change, yes, there might be some contribution from our side, but I think it's more multi-sectoral. It's beyond healthcare workers or health practitioners, or even scientists within the health sector. So I think if we have to tackle this topic, we should have a diversity of of professionals who, would bring a bit of kind of a dialogue, a discourse of trying to define this big elephant, and to kind of allocate some role, who has more responsibility or has more leverage to do more on X. I don't know if I'm making myself understand, but I'm trying to appeal, not to appeal, but trying to see how best we can define and have a kind of straightforward, even to our policymakers, should we have to do research, and straightforward kind of solution in time to inform their decision making on how to tackle this big elephant, which is very complex. Even when you have to put it in the African context, it's even, some people might not even believe about the impact of climate change. So what can be done? And I told you, you mentioned some of the initiatives that are taking place. Would be great to kind of share, or kind of if we can have an expose of some of the solutions, how countries or institutions have really come forward to define and have some solution, particularly by engaging with the upper stream and the lower stream. Thank you.
Well, thank you for that comment. I mean, I can only just agree with you that it is complex, that we need a multi-sectoral approach. In the UCT Faculty of Health Sciences, we teach the primary healthcare approach, which is a comprehensive equity-based approach to healthcare that says, health professionals have to work with other sectors, they have to work as a health team, they have to have equity as the foundation, and they need to include health promotion, a preventive approach, one that looks at the upstream determinants of health. And what that looks like in terms of a health and all policies approach will vary so much from one context to the other, depending on the burden of disease. The Western Cape example that I've shared is obviously particular to our part of Africa. And as we mentioned in the previous response, the healthcare sector itself has a big role to play in mitigating its impact and adapting its services to a climate vulnerable population. So yes, it is complex. I think case studies that are successful and that can be widely shared help people to see the connections, and integrating it finally into our curricula so that our graduates understand the connections and understand that the role they can play in influencing policy and influencing the sustainability of healthcare systems. Thank you.
James, thank you very much for that presentation and your responses. So folks, we are going to take a short break now. We had a 10-minute break planned. So what I think we'd like to try and do is just cut that a little bit. So on my computer, I'm sitting at 11:58 our time. So maybe we could reconvene at 5 past the hour. What I'd suggest is stay logged into the Zoom session. We need to set up the breakout rooms, and so while that's happening, please go and make yourself a cup of coffee, have a comfort break, etc., and we'll try and be back ready to roll as soon as possible after 5 minutes after the hour. So yeah, see you in a little while.
Okay, hi everybody, welcome back. We're ready to just give some quick feedback of the discussions in the 4 breakout groups. Hajira, maybe you can help me because I've forgotten who was in what group, but maybe if you have the list of the of who the rapporteur is in each breakout group, you could just help me along here. But I just wanted to say that from my experience in our breakout group, we had some really good discussions, but we didn't necessarily get all the way to answering all the questions. But so I think our feedback might not fill all the requirements of feedback. So I hope we're not alone in maybe not have getting as far as we had hoped in the discussions. But Hajira, who was group 1?
Okay, so you were actually group 1, and your rapporteur is ACEIR.
Yeah. Okay. So ACEIR, do you want to go ahead and give some our sort of main take-home points from the discussion? Thank you.
Okay. I think from the instruction I was supposed to report on one main issue, right?
Yeah. Okay. Yeah. That's right. So yeah, go for it.
Okay. So from the discussion, one of the main take-home for us was the most vulnerable groups are located in high-risk areas, such as areas prone to air pollution and flooding, and realized that these climate stresses were sort of exacerbating the situation. And we had a typical example where because most of these vulnerable people are located within the coastline, they have high incidence of flooding, and they are displaced from their households, and also they are exposed to all sorts of disease and illnesses, which sort of push them more further into the poverty index scale. Yeah, so that would be for it on from our side.
Perhaps, ACEIR, you could just sort of talk about where we thought an intervention could be made. So the sort of discussions around grassroots, because we sort of wanted to talk a bit about what we thought would be ways forward. Yeah, so maybe mention that one as well. Yeah.
Okay, so for the way forward, we agree that we have a lot of sensitization programs where we tell people about the impact and effect of climate change in an effort to build their adaptive capacities. And there was also a discussion on having more research and finding out like times and intervals as to when these environmental stresses can sort of affect their people's livelihood along the coastline. So these are the things that we touched on basically from our end.
Great, thanks very much. So maybe group 2 then.
Okay, so the second group was Nkechi, and Bonga, I was the rapporteur for that group.
Thanks, Haj. Thanks, Mark. Hi, everyone. From our group, we discussed about like what are the key health issues do we think are linked with climate change and inequalities. we were talking mainly about the non-communicable diseases. We were saying that they are really affected by the issues of inequality in health access and also financial constraints, with especially people in the slums and people in the rural areas. They will not be able to access health services when they are not feeling well or when they are sick. But now on the research gap, so our main issue was, how can we do the research on the linkages between health issues, climate, and inequality? So our main takeaway was, we have to develop a methodology or a framework on how are we going to pick these indicators, or how are we going to include these indicators, these health indicators. For instance, say, if we are talking about a health issue of malaria, it's just whether you have malaria or whether you don't have malaria. And also, we have to do a research on how these the programs that have been implemented to tackle the health problems have had an impact. For example, the intervention might be from WHO or from international organizations, but we still need the research or evidence to see how are these programs affecting the population. Then also on how can the policy change to have an impact on this healthy inequality and climate changes. We said we will need the policymakers to be the policies to be evidence-based, not just from the politicians or from anyone, but from research. And not only the policies should be just on the paper, say, oh, we are going to implement this, we are going to help people with this, but from policy to practice, the policies must be implemented. They must not remain only on papers. We also talked something about non-pharmaceutical intervention, to say we also need to do researches on how can this non-pharmaceutical intervention can help, especially in our African continent, where we have issues of inadequate access to hospitals or the public health care. Yeah, that was from us. Thank you.
Thank you, Bongai.
Okay, thanks, Bongai. We're going to go to the next group. Haj, yeah, go ahead.
That was Darlington. He was assisted by Kagiso.
Okay, thank you. I will talk very briefly and Darlington will complement. So with respect to the interactions, we came up with two main ones. The first one is that climate change reduces agricultural production, makes food scarce, resulting in increased prices and ultimately poverty for people who can't afford it. The second is that climate change reduces the nutritional value of crops, leading to nutritional insecurity and ultimately poor health. With regard to the knowledge gaps, the first one was that we should try to collect data on the environmental factors that may cause illness when patients are being admitted to health facilities. And then the second one was that there's need for a better understanding of how mental health and disability could lead to poverty. And then I think on that score, maybe Darlington can just add a bit more, including on the policy issues. Comments.
Thank you. Okay, so I think for me, I'll just quickly invite Mariette to just share a little bit around the, she gave an example of how sugar tax is affecting other people. Yeah, just on the policy issue. Come through, Mariette.
Hi, thank you for inviting me just to mention that. I was just speaking about how the sugar tax is now, there are suggestions to follow the sugar tax up with taxes on more processed foods. And it is coming from, I suppose, good intentions to try to reduce some of the obesity and diabetic, sort of the cases of obesity and obesity and diabetes. But of course, if these foods are mostly available in rural and informal settlements, who are we going to end up taxing, and who's going to end up paying more for their food? The very people whose health would need more support and whose nutritional security is already endangered.
Thank you.
Right, thanks. And then one final group, right, Sarge?
Yes, that's correct. It was James, and he was assisted by Ruben.
I think, Ruben, are you reporting back?
I'm reporting. Thank you so much. Yeah, so our group, we have discussed in the area of mitigation and adaptation, we have said that if there are proper mitigation and adaptation practices that are carried out in addressing the climate change, they can reduce the health problems in the community. For example, we are talking about the case of where women very much are involved in cooking using the firewood. So we were saying that if we adapt the renewable energy kind of policies, that would lead to use of clean energy, that would reduce some of the diseases like respiratory and others. Adaptation, where people are doing proper farming in areas which have already been affected as a result of drought. So the production of crops in those areas can also address issues of malnutrition. However, we are also trying to see as much as the climate change affects health, we are also saying that health systems can also affect climate change in a way that some of the activities that take place in the hospital, like for example, the use of energy, the plastic waste, the use of drugs, the transports for the sick people, healthcare technology, the fumes, the toxic, the water and sanitation. So we have said all those activities that take place in the health systems can also lead to climate change. So we are saying as we see how the climate change affects health, it is also good also to also have an understanding of how health systems can also lead to climate change in order to have a balance. Thank you.
Great. Thanks, Ruben and James, for that feedback. So I just wanted to we've got sort of 5 or 6 minutes before we need to start finishing off. So I just wanted to give anybody in the audience a chance to add anything they thought was particularly important that had been discussed, that they would like to just bring to everybody's attention. So if you do have something you want to add, then please just raise your hand now. No obligation to do so, but I just don't want everybody to think that their voice hasn't been heard more. So I just wait a few minutes to see if anybody has anything to add. And so far, nobody. So I'm gonna, Marika, please go ahead.
I just wanted to note, I thought our group thought quite an important intervention made by Terry Acheng in our group, where she noted the lack of focus on people with disabilities and people with mental health in a lot of the discussions, where people who are already affected by a lot of other factors, and how further environmental policy, infrastructural changes will make life further difficult for them.
Mm-hmm. Yeah, thanks, Marika. Okay, so we just about ready to finish off. I want to do 2 things in order. So first, I wanted to give Murray Lebrant the chance to just make a few closing remarks. He's my co-conspirator in this, along with everybody else at ACEIR and ARUA-CD in this workshop. So, but then while Murray's talking, it would be great if you could all switch on your videos, because what we're going to do is hopefully by the time Murray's finished, everybody will have their video on, and then Hajira is going to quickly take a photograph of all of the participants together in the standard Zoom screenshot way. I don't know how it works, but anyway, she knows how to work. How it works, yeah. So please, yeah, put on your videos, and Murray, over to you.
Yeah, thank you. Just to thank you all very much for being part of our engagement now. And these issues are obviously complicated and systems issues at some level, but at another level, what I particularly appreciated about the work that we've done together in our small groups and even in the briefings was it brought together the systems issues with the analysis of livelihoods and poverty and inequality and health and nutrition, which resides at that level. It's an outcome of complicated socioeconomic processes in which people have very differential opportunities to do things. And at the same time, there's big climate change negotiations happening, and there's members of this group that have some responsibility really to bring into this discussion what are those dynamics, which policies are being followed, which commitments are being made, and then there's connecting those two worlds together in terms of saying, okay, so what, you know, if the temperature rises by a certain amount, what are the key linkages then back to people and their livelihoods and their health? So we've all got big responsibilities here, but we can't actually do this without each of us playing our role. And so that's what I really appreciated about today's session. We're going to have to proceed this way going forward, but even today was a very useful and fruitful engagement on the way forward. So thank you so much, and thank you to our leading discussants as well, who gave us such a good landscape of this area. I learned a huge amount from James, and from Nkechi as always. That Nkechi and I are soulmates in terms of academic perspective. Anyway, I've spoken long enough for you to all turn on your cameras, so I've served my purpose in some senses, but I really did, I'm genuine in thanking you guys very much. Thanks.